I was shocked to learn that more than 60% of all physicians now work for a corporation in the United States.
Our vision is to build a decentralized health system.
Today I'm sitting down with Alex Barrett, the founder and CEO of Meroka. Now, Alex and his team are trying to take a completely new way at looking at the healthcare industry, where they want to actually restore this whole idea of the independent medical practice and the community doctor. I hope you enjoy, and remember to go direct. Man, how are you doing today?
I am fantastic. How are you?
Good, man. Another going direct conversation with the first time meetings on the recording. So these it's a fun way to meet someone. So welcome.
Thank you. I love that background that you got there.
You like that? So most people don't realize this. It's actually a converted greenhouse. Everyone thinks I'm like in like some sort of like garage or something. But here I can't show because I can't move the camera. But yeah, it's actually a greenhouse. So the other way is actually a garden. So
that's very cool. That's an inspiring space to look out into, I'm sure.
All right, cool. So I've said it before, I'll say it again. Healthcare is the most important system to fix in the United States, hands down. I come from, half my family is full of doctors and nurses. And so this has been a topic of discussion for a long time. And I have a French spouse. And so it's mind-boggling for her to see the state of human health and how the system works when she compares it with her home country. So when Yoni from Slow Ventures, shout out to Yoni, mentioned what you're building, Alex, I was like, couldn't be a better fit around kind of the decentralization of the real economy and the rise of the independent operator. So we'll get into that. And one of the things I'll say is what really caught my eye when I was kind of going through some of your background is you don't have a background in healthcare. And so that made me very excited because I love when people come with fresh perspectives, and what people say is you don't know what you don't know a lot of times. So that definitely caught my eye. And so I'm going to drop a few stats before we hop into it, just to kind of set everything up to level set for the audience. All right. So this is from a 2020 report from Avalier and the Physicians Advocacy Institute. So more than 3/4 of all U.S. doctors are now employed by hospitals, health insurers, private equity, other corporate entities. Rampant consolidation continues to shrink the number of independent physicians. Between 2019 and 2024, more than 44,000 medical practices were acquired. As a result, nearly 60% of all medical practices are now owned by corporations. This is in the United States. And the last thing I'll mention, then I'm going to kick it over to you, Alex. They stated from the research that most physicians who sell their practices do so to better negotiate higher payment rates with health insurers, help manage insurers' administrative and regulatory requirements, and to improve access to expensive resources that they need to run the business. All right, so let's start here. Can you explain the basics of how a medical practice works today from a doctor or owner's perspective?
Sure. And I think it's a good call out that you made that I don't have a healthcare background. Funnily enough, I'm also not American. So
Canadian, right?
I'm a Canadian sort of business person that took on the challenge of trying to solve one of the biggest problems in US healthcare. The good news is that your question around how businesses work is like these medical businesses are actually relatively simple. These independent practices are typically formed in one of two ways. Either there's a single owner doctor, or it's a partnership amongst a number of physicians. Those are the two most common ways an independent practice would be owned. And their businesses are relatively simple. They have one revenue line item in most cases, which is revenue from seeing patients and payer reimbursements. And their costs are divided across probably 10 different lines, but there's 3 or 4 really big ones, which would be rent, payroll, their EMR system, and their malpractice insurance. And that's usually the construct of a business in the healthcare space. And obviously the game of any business is making sure that revenue from services is greater than the costs. And unfortunately, what we've seen over the last 20 years or so is that reimbursement rates across the board are pretty much flat. They're flat if you look at it on a graph. If you actually inflation adjust it, they're significantly down. And costs are very high, especially in a post-COVID world where we've seen a lot of inflation. The cost of pretty much every line item in a business has increased. And so when you have this business environment where revenues are flat or declining and costs are rising in an inflationary world, the P&L starts to invert, and that's where you have a real problem for independent practices. So that's the basic way a business is owned and run in the independent space, and why you're seeing so many of them have challenges.
Question for you on reimbursement rates. And you mentioned they're kind of flat. So if you were to, so is that flat on like an inflation adjusted basis, or it actually is? It's actually lower. It's actually stayed flat from like a real, from a nominal standpoint.
Standpoint. Yeah. So if you look at it, there's this great chart, which I can try to send you afterwards. That's been sort of circulated all around social media and over the last little while, which basically shows this, big upward sloping line, which is the average cost of doing business, or like sort of the CP, the inflation over the last 20 years. And then there's this also big upward sloping line that sort of matches that line, which is hospital reimbursement rates. And then all the way down at the bottom of the chart, there's this flat line near zero, which is the sort of real reimbursement rates from Medicare over the last 20 years. And this is a chart that's, it's not data that I created. It's something that's out there. And so if you just compare the 20-year rates of reimbursement, and everything's based off Medicare reimbursement, it's nearly flat, or it's somewhere between 0 and 10%. But if you look at it on an inflation adjusted basis, it would actually be negative.
Man, okay. Yeah, and then it's interesting, like just for folks out there that might not be
Yeah.
as knowledgeable about some of these terms, but then what just to simplify what Alex was saying is your revenue is not going up, but the inputs, because everything else has inflation, right? All the equipment you're buying and everything else that you're buying to actually in the rent you're paying, is all increasing. So just to simplify. Okay, so can you walk me through a little bit to make sure? First, I want to understand, and the folks that are listening understand, like I've kind of, from my research, there's kind of three different models, I would say, or kind of ownership models for a doctor's practice. I have here hospital and health system owned. And then kind of the second bucket being health insurers, pharmacy chains, and private equity firms. And then you kind of have the third bucket being this independent practice. Is that the right way to like think about it or frame it up?
Yeah, those are definitely the three ownership models in healthcare. And this is an industry that back in the 80s was largely in that last bucket that you said, largely independent owned. These practices would even transition through generations, right? You'd have in the family, you'd have, kids that become doctors and take over the practice. And there was this sort of pride and proudness around having an independent practice, being the center of your community. Even talk to doctors today in small towns where they get recognized in the street, right? In the bookstore, the coffee shop, and there was this pride of serving your community as a doctor. And I think what you've seen over time is basically a swing from that last independent bucket into some of those others. So the largest employer of physicians now in the country is United Health, which is a payer, and the other payers followed suit as well. Obviously, they employ a lot of physicians through entities that they own. In the case of United Health, it's through Optum. And then you also have a lot of private equity firms and other corporate entities that have gotten into the business of operating medical practices and employing doctors.
How did that happen where they started to allow, like, for instance, the insurers to actually own practices, and like they just did it all through, like, is it kind of a shell game, or how does that work?
Yeah, I mean, I don't know that I want to, deeply explore the payer business model. I think there was a couple of legislations that changed the game there, where I think there was a cap made on how much you can actually earn as an insurance company, right? Where you had to redistribute most of the proceeds of insurance as expenses. So in terms of like a gross margin for an insurance company, I think there was a cap placed on them where they could only earn sort of 20 or 15% gross margins. And so basically they needed to find other places in the healthcare system to be able to earn larger margins. And so that's why they start opening up pharmacies and ancillary services and direct to physician practices, but because you can reinvest the expenses back into some of those other business line items and actually grow the business. So this is a classic case of like deep vertical integration, right? It's like, let's just get involved in every layer of the chain. We've seen it in other industries too, not just in healthcare. But these payers, which now often get termed payviders because they both pay and provide care, it's basically a way to reinvest the proceeds in entities and businesses that you also run and you also own. And I'm not here to throw necessarily every single one of their practices under the bus, right? There's Optum clinics that deliver great care. There's great doctors that work for those businesses. There's great private equity run practices as well. The unfortunate thing is, like, on average, if you were to just poll physicians across the country on average, obviously burnout rates are really high. Obviously, the feeling of autonomy and ownership is really low, especially when you work for some of those corporate entities. So, we're not up here at Meroka saying like, "Hey, we're going to go deliver better care or something, or we're going to, build a better business model." What we are saying is we're trying to restore that feeling of ownership and autonomy and that connection to the community. And we think that that comes by, name of your podcast, but going direct, right? Going direct from independent business owner straight to patient, and sort of eliminating some of those corporate systems that have gotten in the middle over the last couple of decades.
Man, it's funny you hit on this point for me, which is like the whole motivation with going direct is, and you can really say it about it's across nearly every aspect of of our lives. We're just completely disconnected from the products that we consume and the services that we receive, man. And I'm looking at this and I'm like, no one, it's interesting. No one's covering it in the sense of like this. Everyone talks about loneliness and loneliness epidemic and all stuff. It's all connected exactly what you're talking about.
Yeah.
It's like, I don't know, man, it cuts really, really, really deep that, um, and so anyways, I'm excited to dig into what you guys are building. So I wanted to do one thing before we hop over into Meroka. At the beginning, I mentioned that there are three main reasons why physicians sell their practices. So I was wondering if you could help me unpack kind of each one or what's kind of gone on in the industry of why it is this way. So the first one was they do so to negotiate higher payment rates with the health insurer. So why is that the case?
So, reimbursement rates are the main source of revenue for a medical practice. So, I deliver a service as a medical practitioner, and I need to be reimbursed for that service somewhere. So, I can be reimbursed by the government, either through Medicare or Medicaid, if I'm seeing a patient that's either over the age of 65, disabled, or qualifies for Medicaid based on their socioeconomic status, or I can be reimbursed by a commercial insurance plan. Alternatively, I can be reimbursed by a credit card, right? If I'm a cash pay practice where I charge just credit services at my front desk. And so these reimbursement rates are critical to these practices being alive. Unfortunately, Medicare publishes reimbursement rates for a given procedure as a baseline sort of metric every January. Every plan, then every commercial insurance plan, every other plan builds off of Medicare. And so you'll see that most of these private practices have some benchmark to Medicare. Some of them are making 80% of Medicare, 90% of Medicare, 120% of Medicare, but everything's sort of based off of that benchmark. And that rate of Medicare that you receive depends on your negotiating leverage with the insurance carriers. So you need to be able to do a number of things to be able to improve that reimbursement rate. One is, control more market density in that region, because obviously the payers want their beneficiaries in that area to be able to see the best clinics, have enough network in their regions. And so if you control more locations in a region, chances are you're going to have a better relationship and a better opportunity to negotiate with that payer. If you save the payer money, so if you deliver higher quality of care at lower cost, you might have a better chance negotiating with that payer. And so I think what one of the early opportunities was for the corporatization of medicine was like, hey, what if we buy up a whole bunch of practices in the same region, give the payer a call and say, look, now you sort of got to work with us, right? Because we're a dominant force in this region. I'm giving this example in the payer negotiation landscape. Most things that you talk about in the country related to scale, it's the same dynamic. Everybody's familiar with GPOs around like, how do I purchase supplies? Most people know that, in any industry, the more scale that you buy at, the better price you're going to get. It's why Costco has a business model, right? It's very similar in the medical industry. It's like the more scale you get in terms of the number of providers that you manage in a given region, the better chance you're going to have negotiating for a higher rate of Medicare with these insurance companies. So that was one of the main impetus for consolidation and why we've seen such an acceleration in medical practice consolidation over time. Unfortunately, it leads to some potentially dangerous behaviors, right? It incentivizes monopolization. It incentivizes high density in a region. So you'll see some of the strategies here is let's pick one small town and let's try to buy up 50% of the practices in a given specialty because we're really going to control the negotiating leverage in that space. And so it's led to some really weird competitive dynamics in some cases. And that's sort of the downfall of that approach.
It's interesting to me that, a reimbursement rate wouldn't just be a reimbursement rate and like that's what it is. Has it always been that way where there's like it's always been negotiable and I mean for the last 20, 30 years?
I mean, it's a service, right? If we oftentimes medical stuff sounds complicated, but if you think about any other service that you buy, getting a procedure from a dentist is going to cost a different amount at different dentist offices, even if you might be paying cash. Buying a pizza at different restaurants is going to cost a different price, right? Depending on the ambiance in that restaurant, depending on the quality of staff depending on the type of patients that they or clientele that they service. So in some rundown rural town pizza joint that has wooden chairs and no air conditioning, like you're paying a different price for the pizza than you are in a bougie place in downtown Manhattan where you're getting wined and dined on your way in the front door. It's all those things are taken into consideration in the way that the service is being delivered, and it's similar for medical services, right? Practices that treat commercially insured, highly affluent people have to invest more in the decor and in the furniture in the office, and they have to invest more in the reception experience and how you're filling out your forms on an iPad versus it. And so the reimbursement rates in some cases need to be able to offset that. And so the quality of service, the quality of care, the staff you're able to recruit, all those things play into the reimbursement rates that you might be able to receive. So that's why it's variable in some cases. The problem is it's very variable, right? Where you'll see some independent practices that are earning 80% of Medicare, and the hospital system down the street for the same procedure might be getting 300% of Medicare
Serious?
for the
That
same
big of
thing. And so the spread is
wow.
large. It's a really large spread. It's like paying $50 for a slice of pizza or something when you can, on the street of New York get it for two. It's a really, really big spread.
Man. Okay. Second, it was helping manage the insurer's administrative and regulatory requirements. There was a reason why they would sell. So can you unpack that a little bit for us?
There's a lot of stresses in running a practice. Like, first and foremost, practice owners are entrepreneurs. And I strongly believe that. They'll call themselves doctors. Like, anybody who owns any business is an entrepreneur. You go to school to study medicine, and then you got to figure everything else out, from how to open the door in the morning to how to manage your business, how to hire people, fire people, marketing, finance. You got to figure everything out. And they do a tremendous job at doing this. Collecting on your reimbursements is a real challenge. That's why you have an entire industry in the United States called revenue cycle management, which is the entire revenue cycle piece of a practice. And it's very complicated. You need to make sure that you've enrolled with payers and that you have a contract with every single insurance company that you want to bill with. You need to make sure that you eligibility check every single patient. You need to make sure that you might have to get prior authorization for certain procedures that you have to perform. Then you have to actually take notes during your visit, record those notes, turn them into a code which corresponds to your payer contract, bill that code in an adequate fashion to the payer, ensure that what you received back is actually the correct amount, and if not, appeal that claim or that denial or that underpayment, and then reconcile all this in an entire system that adds up at the end of the day to that one line item in your P&L, which is revenue. So managing that flow and that process is really, really cumbersome. It's really hard to do well as an independent business. And most independent practices that we talk to, that job that I just described is done by them late at night, by their spouse, oftentimes, late at night or on Sunday mornings. And so this is a real administrative burden, and it's crucial because you don't get paid if you don't do it well. So, a couple of things there is we talk about the concept of pajama time, right? Sitting on the couch at night, like pajama time for these physicians with their glass of wine, like watching a soap opera. It's like they're in front of them is their codes and their bills, and they're looking at that stuff at 10 o'clock at night. And what we see typically in these independent businesses is they only collect on about 60 to 70% of the revenue that they bill. And that's because somewhere in that chain that I just described, be it you don't know what your contract is, you didn't do the right eligibility check in time, you didn't get authorization for the procedure, you didn't code the thing properly, your notes weren't adequate, something broke, and it resulted in you not getting paid the full value of the procedure you should have been getting paid for. And so it's crucial that you get that right. You're leaving a lot of money on the table if you don't.
Oh, okay. Third.
Yeah.
It's just layered. It's just layered. And
Yeah.
it's crazy, man. I mean, as a Canadian, you're probably like, this is just crazy. The more that you're getting into the US system, but it's just layered. And it's just every time I'm hearing this, I'm like, we're just getting further and further away of like the actual point of what this whole thing is, which is to keep people healthy.
Yeah.
The last one of what it's cited as one of the main reasons why the independent physicians are selling their practices are the improved access to expensive resources to run the practice. So, is there any anecdote you have there?
So I mentioned some of the main line items in the P&L. One of the biggest costs for a practice is their EMR and or billing system. It's the critical piece of technology that both manages everything I just described, but also manages patient records and all your patient data and database. These are expensive platforms, and so there's a swath of them. Right, there's 1,000 systems across the country that do this. There's probably a dozen or so that are prevalent across independent practices, and they're not the best dozen, right? So the health systems or the larger entities have access to better software at better rates. There's been entire roll-up businesses built on arbitrage in billing system rates, right? Where practices are paying 7%, but as a scaled entity, I'm paying 3%. And that 4% delta is the difference between profitability and unprofitability. So yeah, access to better resources would be a better technology, as I just described that example, better group purchasing for my medical supplies, better insurance. So my malpractice insurance, my employee health and benefits insurance, those are things that are scalable with volume, and access to quality of talent too. So what we're seeing is you said a stat at the beginning, which is something around 70%. I think you said three-fourths, but I think it's somewhere between 70 and 75% of physicians are employed by some entity. What we see is that actually 90% plus of new graduates go into some corporate entity. So that
Interesting.
70-ish% hasn't reached an upper maximum yet, because the funnel is actually still going predominantly there in either as a higher rate. So these independent practices struggle big time to recruit quality talent. They have a high turnover of frontline staff, let's say receptionists, medical assistants. And then in terms of like physicians and nurses, it's really hard to get high quality and pay them market competitive rates. So that's another reason, is that they get access to more talent, sort of staffing backfills. I'll give you an example. We work predominantly in the OBGYN space. OBGYNs are obstetrics and gynecologists. They're women's health doctors. And one of the main things that obstetrics and gynecologists do is deliver babies. This is a great example of resourcing, because if you're trying to run a two-physician obstetrics practice, guess what? You're only two physicians to deliver babies. For a call schedule, which is potentially 24 hours a day, right? Your patient might have a delivery in the middle of the night, and you're only dividing all those hours up amongst two of you. In a hospital system, there might be 200. So all of a sudden, the call schedule where you're available 24/7, now you might only need to be on call once every 2 weeks. And so put that in front of a new graduate in obstetrics. Do you want to join an independent practice where your phone's got to be beside you when you're sleeping every single night? Or do you want to join the health system where you still get to be the obstetrician, you still get paid probably more, and your call schedule is quite light? And that's the sort of dynamic. You can use that example across all specialties where talent is accruing to the consolidated entities. Um,
Yeah, it's interesting in France. I know because I've had children in France, or my wife has, and it's interesting because the midwives or the nurse, they have their own. We don't have the midwife thing in the U.S., but the nurses are the ones that actually deliver the baby. And so like we didn't even, I think for our second child, we didn't even, there wasn't even a doctor in the room. So it's interesting how different systems work, which we'll get into. All right, so let's move over to Meroka. So I'm gonna give the coin or the communication right from the website, and then you can drill into it. Okay. So Meroka partners with physician-owned medical practices to transition ownership to the employees of the practice through an innovative model. that empowers the practice with cutting edge technology to ensure long term success and keep the practice in the hands of the community. So let's break that down about actually what you're doing and why you're dedicating your life at this point to doing it.
Yeah, maybe I could tell you a little bit about the founding story. So I've been in the early stage entrepreneurial technology space for the last 12 years or so of my career. I originally am a finance person. I have a CPA, I'm a CFA, and I worked for a fund where I invested in really early stage technology businesses. So I was brainstorming with the two people that started a business on a whiteboard in the garage, trying to dream up what the next phase of that business would be and deciding whether I wanted to put some very long term, very risky capital behind those people. And I did that for about 5 years. And then I ended up joining one of the companies that I had invested in as we were scaling. It was a business in the construction space where we were delivering construction materials to job sites. It was very much focused on small business owners again. It was focused on small business contractors that were wasting a ton of time on materials and had no scale and had no capacity to do anything. And I joined that business. We built it up to about $100 million of revenue and 600 employees. And one of the projects I was working on in that business was actually going and buying lumber yards. We were thinking that in order to get deeper into the supply chain of delivering materials, that we might as well partner in a deeper way with the lumber suppliers. And I had this crazy realization as I traveled across the United States meeting lumberyard owners. I kept showing up at these lumber yards where there's an 80-year-old owning the business, and he's got 10 offers from private equity firms. And I'm like, why in God's name are private equity buying this lumber yard from this 80-year-old man in rural Illinois? And I sort of took a step back and was like, this has got to be about more than just generational transition. Like, yeah, I understand that like the baby boomers are getting older and like we're seeing this silver tsunami kind of thing of like what's going to happen to all these businesses. But like, what's private equity's interest in like a city little lumber yard in rural Chicago or rural Illinois? I decided to step away and dedicate 6 months to that research. And I very quickly in that 6 months ended up in healthcare because it was the industry where this was happening in the most, broad and scaled and prevalent way. And I decided that I wanted to try to solve that problem for predominantly for entrepreneurs. I wasn't even thinking about them as doctors in the moment. I was thinking about them as small business owners, as people that have built this business. And if you think about the difference between the 80s and 2010 or 2015, all that money, all that economic value that was going into the pockets of individuals and families and being reinvested in the communities is now corporate profit. And that has a huge long-term effect on income equality. We already have an income equality problem in the country where, you see a shrinking middle class. And I think long term, if what happens to all these small business assets if they all end up in the hands of corporations versus in the hands of individuals, that income equality problem just gets worse. And so what I did was step back and say, like, what would the right ownership infrastructure look like for a small business? Like, it's not realistic that it's the same owner. Like, look, some owners need to sell. Like, we understand that they're either retiring or they're getting older or they can't run the business anymore or they've tapped out, right? But there's got to be an option other than health system or private equity firm or payer, right? There's got to be some other thing. And like to me, like what better owner than the staff on site that delivers care? They already have the relationships with the patients. They're already in the community. They're already the generators of value in the business. Why not make them the beneficial owners of the practice? So that's the founding insight and the inkling that made us go on this journey. And I think what we quickly realized, and that's where the sort of technology stuff comes into this, is what we quickly realized is that the state of these independent practices, for all the reasons we just talked about, is worse than we thought. We thought we were going to meet this 30% of the market that are independents, that these were great businesses, that we were just going to take ownership from the existing owner, reallocate it to the employees. And we realized, like, look, taking shares from one pocket and putting it in the other doesn't solve the fact that these businesses are in a really, really dire state. And so we said, like, this ownership infrastructure is but one of two components of actually setting this practice up for success in the future. We have to tech enable it so that it can get access to all the resources you're talking about. It can get access to quality talent. It can take some of that burden off of them. And so the combination of that tech enablement and ownership and empowerment are what we think allows this business to be still running in 20 years as an independent business versus having to either close its doors or sell itself short.
So in a way, if I understand correctly, so you think you're thinking things about like I just my mind goes to GPOs,
Mm-hmm.
which is a whole other
Mm-hmm.
conversation, but it's kind of
Yeah.
this idea that kind of building this back end and operational
Mm-hmm.
infrastructure while maintaining the independent ownership of the practices, you can help with a lot of things that like a traditional GPO might help with. Is that kind of generally how to think about it? Or
Yeah, I'll say something like somewhat controversial, which is I think the most commonly held belief in healthcare consolidation is that the only way to drive value to a business in the healthcare space is to get them better reimbursement rates through payer leverage. And that insight, that commonly held wisdom is what's led to all consolidation. Everybody says, okay, P&L answer is reimbursement rates. Let me consolidate and monopolize. If that answer is true, I don't want to run Meroka. I don't want to run a business where the only leverage to be had on a practice is through reimbursement rates, because then your entire strategy needs to be about consolidation. So while we may help at some point with negotiating leverage, that's not the way we're trying to drive value to a practice. What we're doing is actually one of the first things you said, which is our vision is to build a decentralized health system. A decentralized health system means that power gets pushed to the edges, right? And the individuals that run their businesses are the ones in control. And to truly build a decentralized health systems, these businesses need to be sustainable on a standalone basis. If they're only sustainable in a group, it doesn't work. It's not decentralized, truly. So we want to make them sustainable on an individual basis, which means you need to push power to them on an individual basis. And so, our belief is that through tech enablement, we'll be able to drive value to small independent practices in absence of them being part of a group. And that's really the vision. We aspire to be a company like Shopify. If you reflect on Shopify, and they're obviously a $100 billion plus company now, but Shopify enabled e-commerce entrepreneurs to run and manage their own business. Every business on Shopify is owned by the entrepreneur. Shopify doesn't own businesses, right? They empower those individual businesses to be sustainable on an individual right, and they take a license fee in order to do that. That is our business model. Our business model is let's make these independently empowered businesses sustainable on an individual right, and let's charge a service fee in order for us to enable that future. We don't participate in their EBITDA. We don't participate in their economic earnings or distributions. We want to make them sustainable, independent businesses.
understood. So if I'm an OBGYN and I work with you, just kind of give me broad strokes of how I have my own independent practice. And so like, yeah, give me how that's kind of generally structured or how that's approached.
Yeah, so the transaction consists of obviously providing some liquidity to the seller because they've built something of value, leaving the employees as the beneficial owners of the business. And so there's an ownership transfer that happens from selling physician to remaining staff.
Day one,
Um,
or like as part of this
Mhm.
transaction.
As part of this
Okay.
transaction.
Okay.
And our consideration in exchange for funding that transaction and transitioning ownership to the staff is that we take a managed service agreement with the practice, and we manage some of the things that we just talked about that we can help tech enable with into the future. To the extent that our software and tech enablement drives more value to the practice, that's owned by the staff. So they're the beneficiaries of that. And it's important to note when I say staff, because sometimes people in the medical field, when I say staff, I mean every single person in that business that's on payroll. So
Okay.
be it the receptionist, medical assistant, students that may cycle through there, nurses, physicians, billers, coders, everybody. It's a full employee ownership of business.
Got it. So yeah, so you work through those details out with the selling physician, and obviously case by case. I'm sure you have some sort of template or structure, and then as a case by case basis. Okay. Okay. So I have to prompt this because I think folks that don't think about these types of things like you and I do will be like, how is this like different than private equity? So talk to me about, the role of private equity in healthcare and how this is something fundamentally different.
There's one really, really big difference. And the difference is the time frame. Not all private equity is bad. I have friends that run healthcare rollups. I have friends that do it in a way that where culture is really great. And actually, if you polled some of their staff, they'd say it's great. There's also some horrible ones, and that's the case with anything. Private equity is a capital partner. They are deploying capital into a business, hoping that they can return more capital in that business over time. And private equity has realized one key intuition, which is that the size of your platform dictates how much the platform is worth. So if I have one business, it might trade at, let's say, 3x earnings. But if I have 20 businesses, they'll all trade at, let's say, 7x earnings. And what we do is we call that multiples arbitrage. By nature of assembling a larger platform, the value of all of the earnings increase. And so that's the goal of a private equity firm, is assemble more assets so that there's an arbitrage on the multiple I paid versus the multiple that I sell it for. That business model relies on two key things. It relies on having a relatively short time frame. And when I say relatively short, I mean typically between 4 and 8 years. And it relies on reselling the platform. The only way the private equity firm makes money is by reselling that packaged platform that they built, which means that ownership changes twice, right? You're buying the practice today, but you're reselling the practice within 4 to 8 years. And so there's two transitions that happen. Why is that, not great in some cases? Number one, the physician at time zero doesn't know who the long-term owner of the business is. They don't know who that platform gets resold to. So even if they like the private equity firm they're working with today, they might not like the one that rebuys it in 7 years. Their staff might not like that one that rebuys it. The other thing is, on that short-term time frame, if you're talking about 4, 6, 7 years, you're incentivized to do different things. Technology is a long-term thing, right? When you invest in a technology business, you're hoping for returns in 10 to 20 years. So private equity firms don't make those technology investments because of the short time frame. They make different sorts of bets, right? They'll centralize call centers, they'll cost optimize, they'll do some of those things because it improves the profitability of the practice. But it's a short-term profitability improvement. It's not a long-term value unlocker. So that's sort of the way to think about private equity. And again, not all bad. It's that the short-term time frame and the desire to return capital through another sale sort of limits the model in terms of its value. The Meroka model, the way we set it up as an employee-owned entity, it never gets resold. So again, we monetize through a managed service agreement, through providing value to the practice. We don't monetize by reselling the business. So it's a perpetual ownership structure. It can last for decades and decades and decades, so long as there's staff that are employed and running that business. It never needs to be resold again. So there's power in that because, again, it changes the time frame behind your investments. Now I can make an investment that doesn't pay back in the short term because it's a more long-term structure. Now I don't need to worry about who the next buyer of the business is. So those are just some basic examples of where our structure, if your desire as an owner is to keep this business private and independent, is a more advantageous one.
Got it. And how you made this comment before where there's some liquidity for the selling owner. So I assume you guys come and do you provide that liquidity as Meroka?
Yes.
Okay. And so can you talk a little bit about how you're kind of thinking about how you've capitalized the business? And the reason why I'm asking this is what you started out with private equity, which I've always tried to explain to people, is you have to understand how their incentive structures work and how their capital strategies
Yes.
work. And so I think it's important to drill into that a little bit because I'm sure you've thought a lot about this, especially with the finance background. So you're not limited or your incentive structures misalign with the ultimate objective with what you're doing.
Yeah. So we raise capital in two forms. One is venture capital funding from folks like Yoni from Flow, who you had on this podcast. These are long-term investors. They're investors that are looking, decade out in terms of how to return their capital, and they invest in businesses like ours that take really interesting big bets on changing big markets. And so that's what funds things like our corporate overhead, our investments in technology, our research and development. In terms of what allows us to provide more liquidity to practices, there's actually lots of commercial debt out there for businesses like this, especially in an employee ownership context. So there are about 7,000 employee owned businesses across the United States. There's an entire industry of commercial banks that fund employee ownership transitions at actually very attractive and favorable terms. They are very willing to work with us. And so because we're a well-funded business, because we're a company that manages these practices in an interesting way, in a sophisticated way. We actually de-risk the pool of that capital, and so we're able to leverage some of that employee ownership type of commercial debt that we can actually fund these things at pretty attractively.
Great. That's super helpful. Thanks. So, do you work with practices both that are reimbursed as well as private pay, or do you veer towards one or the other, or really it doesn't matter?
Today, we work only with practices whose predominant revenue streams are reimbursements from insurance payers. And the reason being is we've built a lot of technology to solve that problem. So the entire system that I talked you through before of intaking a patient all the way through collecting and receiving that revenue is where we spent most of our research and development dollars and technology development. And so that's a problem that we're uniquely positioned to solve. And we want to work with practices where it's a big problem for them. So cash pay is a different business. In some ways, those cash pay practices are more profitable. They actually they don't have the same software needs. They run their businesses a little bit differently when they don't have to worry about insurance payers. So we may get there at some point, but that's not our initial focus as a business.
And when did you start it?
In mid 2023,
Okay, so about a year and a half in ish,
almost 2 years. Yeah.
almost 2 years. Okay, and how many practices have you worked, or have you kind of done this model with thus far?
Yeah, we worked on our first five, which we took about a year to launch. We had a lot of work to do, obviously, on building some technology, building this ownership model as well. This is a very, what I've described in terms of medical practice ownership and employee ownership is a very complicated thing to do in terms of different corporate practice of medicine laws that we need to respect. Obviously, a whole bunch of healthcare regulatory laws, which we're very adherent and compliant to. So there's a lot of structuring. It's not as easy as buying a restaurant or a car shop, right? So we had to develop. There's a lot of uniqueness and secret sauce in there that makes this all possible. And so we officially launched with customers in the fall of 2024. Our goal was to bring on our first five in the first few months and make sure that we're adding a lot of value to those businesses. I think a lot of folks in the venture context talk about scale, and what I want to make sure is that we're delivering value before we hit the gas pedal on scale. The last thing I want to be doing is managing 100 businesses poorly. I think it's a lot harder than we've made it sound on this podcast to actually provide the right support to these transitioning practices, and we want to make sure that we nail that playbook.
Well, you hit on something where it just drives me crazy. As an active angel, it drives me crazy. And it's just because this idea of like venture and fundraising has been just like romanticized. It's fascinating where I find there's like this whole generation of entrepreneurs and people starting businesses where it's gotten a lot of times so far away from like the point of starting the business, which is like,
Yeah.
to me, a true entrepreneur is someone that is like sees a problem that is just not being solved and is just like obsessive over solving that. We're scale, 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 scale. No, it's like solve the problem, do it extremely, extremely well, and then the rest takes care of itself. That's my kind of philosophy, but I don't know.
So I'll steal this concept from Yoni, which he might have said on here, or he definitely has a blog post about. But every stage of a business like ours is about flipping one card, right? It's as if you're playing poker, and with every card that you flip, you get more information, right? And that more information tells you what to do with your hand, tells you whether to bet more, double down, where to invest. And so, like, what you really need to ask is, like, what card are we flipping as a business at this moment in time? We do not need to flip the card that asks the question, like, are there a lot of independent practices in need? Like, obviously there are. There are thousands of independent practices in need of solving this problem. We've seen it through the level of consolidation. We've seen it through all the data that you shared and the conversation we had about their biggest problems that they're facing. That's not a card we need to flip. We already have that answer. The card we need to flip is, can we meaningfully help them? Because that's the only thing that matters. Again, it doesn't matter if you take ownership from one pocket and put it in the other. If this business is not sustainable in the current healthcare landscape, knowing that it's 70% consolidated, knowing that reimbursements are flat, knowing that costs are high, that business is not sustainable. You actually don't want to work with 200 of them, right? The card we flip is the card around, like, can we improve economic value through tech enablement? And if that card is true, I'm very confident we'll be working with hundreds of practices very, very quickly. But we got to get that answer in the shortest time frame we can. That's our jobs.
Does content And social media content play a role here at all? We're
It
really
does,
helping them.
and it will. Yeah. In terms of the medical practice, so
Yes.
what's interesting is you got to look at every single specialty a little bit differently. So if you're imagining OBGYN to continue with that example, who are the standard patients for an OBGYN? They're women between the ages of 25 and 40. And women between the ages of 25 and 40 today are on different platforms than they were 10 or 20 years ago. And so if you're an OBGYN thinking about marketing and advertising, you need to be aware of where that patient demographic lives because your patients actually don't age with you. They're always between the ages of 25 and 40. So they're OBGYN, they're trying to figure out TikTok. They're trying to figure out different content engines and social media strategies. And that's things that they have to learn. That's back to this like entrepreneurial thing. It's like it never stops, right? You've got 70-year-old OBGYNs figuring out TikTok to try to market to the next generation of women giving birth. It's a fun challenge.
Yeah, I think about it a lot because, you think about just where people's attention are, and right, and obviously that's where people's
Yeah.
attention are. So, okay, one other question for you, and then we'll move on. I find it fascinating that you're Canadian working in the U.S. on this problem, and we have two very different types of healthcare systems. So, I don't know, maybe just I don't know, has that like have you taken insights from like how the Canadian system works, or like I don't know, has that played a role in anything that you're doing at all? I was just curious about that.
It's funny, all my friends in Canada, now that they know that I run a healthcare business, ask me a lot of questions about healthcare. And I actually know very little about Canadian healthcare. I've spent all my time focused on the American market. All I know about Canadian healthcare is my experience as a consumer of the Canadian healthcare product. In some ways, there's not a lot of inspiration to take from it. There are very different systems. And while sometimes it sounds, rosy in Canada, ultimately it's an accessibility versus affordability difference, right? In the United States, healthcare is struggles from affordability, but actually accessibility is very good. If you need to see a doctor pretty much in any specialty, it is accessible to you. It is, though, restricted for people that have the ability to afford it. And in Canada, in some cases, it's the opposite. Healthcare is publicly funded, typically across every single specialty. It's mostly in the hospital system, so you don't have a lot of independent practices. But the accessibility is a real challenge. The ER wait times are very long. The specialists are restricted through gatekeepers, which are primary care physicians. And the wait list for primary care physicians in my province is, I think, 10 years long. And so it's a real challenge. It's an overheated system. We saw it during the pandemic how certain places in Canada had to respond to that. And so it's not grass is not always greener, I guess, having experienced as a consumer now both systems. And there's definitely the problems are very different, but neither are without problem.
Why are you doing this work? Why did you decide to take this on?
I love the challenge of solving hard problems. I think this is probably one of the biggest and hardest problems you can solve. It's the largest contributor of GDP. It's one of the most impactful industries. I love tangibility as well. I was talking to you about running that construction business, like being able to show up on a job site with materials and bring them. And like, it's the same thing with a practice, like being able to go in and like see the inner workings of a brick and mortar business. But fundamentally, like those are my own personal ambitions. I love operations. I love tangibility. I love small business owners. Is like this entrepreneurial mindset. Like that's why I was bringing up the example of Shopify. Like I'm motivated by enabling entrepreneurship. I'm an entrepreneur. I spent time investing in entrepreneurs. I've spent time on the board of entrepreneurs. That's been my entire professional career. I love inspiring other entrepreneurs, and I don't think doctors get enough respect for their entrepreneurial ambitions as they should. I think doctors are sick and tired of people saying, "Oh, you're a doctor, like you're not a business person. You see patients. Let me manage your business." In some ways, it's kind of bullshit. They do a great job at managing their business. The odds are just stacked against them, and that's the case for all entrepreneurs. It's the case for us starting this business. The odds are heavily stacked against us. Like we should fail at doing this. That's the default path. Like we will probably fail, and like that's what motivates me ultimately. So we're in some ways that's the challenge that we find. So
Yeah, man, it's pretty crazy that when I stepped back and I was like thinking a lot about going direct and the decentralization of the real world. And it's just the reality is this. You kind of mentioned it doesn't matter what you're looking at, whether it's healthcare, it can be retail, it can be supermarkets. It's just, and this happens just throughout history, right? Human history, where you get systems that become centralized and they become too sclerotic and too inefficient. And then it goes back into decentralization and they come back
Yeah.
and centralize. And so I think what you hit on is just spot on. I mean, this is the whole point of this, which is we're at a time right now where we have multiple technological trends coming together and enabling technologies to enable this. And no, it's to be honest, it's very, I get a lot of energy similar to you, actually. I tell people all the time, I'm like, just speaking with other people that are just so into what they do, they don't have
Yeah.
to be starting their own business, but when I meet someone and they're just like so into it and you can feel it. And I'm like, man, it just gives me so much energy. And then when I'm around a bunch of people that are just like, no energy for what they're doing, they're just going through their daily lives. I'm like, man, it just drains me. It's like, I'm like, I see so many problems, so many things I want to work on. I wish I could do 100 things at once.
Yeah. Yeah. I feel you.
All right. So we'll wrap up here with a little bit of a kind of a rapid fire for you if you're down for it. What's a health trend that you'd like to see die?
That's a good one. I don't know. There's this store near our office that sells all these longevity mushrooms and all these there's like entire shelves of drinks that are this big that are cost $15. Like I question I question some of that. Yeah.
I'm just like, just eat good
Yeah.
food,
Yeah.
and it's all good.
Exercise. Yeah,
Yeah.
exactly.
What's one myth in the healthcare world that kind of drives you nuts?
I think I just said it actually. This myth that doctors aren't business people. I hear it all the time on podcasts, on blog posts. Like, you will manage your business, you see your patients. It really minimizes their capabilities. These are really, really smart, driven, ambitious people.
Most surprising thing you've learned since being knee deep in the world of US healthcare?
One of the things that's interesting is like everybody talks about business succession or business transition. And I think what I've learned is it's a line, not a dot. Business succession is a long period. These people have been running their businesses for 30 years. They're not exiting tomorrow. They care deeply about this business. So I think what I've learned in some ways is like what these physicians need is lifestyle, freedom, joy, lifestyle. They don't want to walk away from their practice or their patients. They want the ability to like go mentor some new grads or teach or go, like, we have one of our physicians is in Uganda at a Fulbright scholarship. Another one was like in Kenya, training gynecologists. Like, they want the ability to do these things without their business burning down while they're gone. That's all they're asking for. And if that can come true, they might work for another 10 years. So I think transition is really a long period of time.
Can you give me one name of someone that has had a big effect, and you can be with personal or professional, that's really been inspired you or a big effect in your life?
Just because it's top of mind, I think Yoni would be a relevant one. Yoni backed this business from the first dollar in. We wouldn't exist today if it wasn't for his support in what we're doing. I can very, very easily say that it's a big, risky endeavor that we're taking on, and we owe a lot of it to his support and to tying his brand to what we're doing. And it was at a time in my life where um, I was obviously working in the construction business. I was working other things, and like, didn't know what my future was about. Didn't know what country it was in, what industry it was in, what world it was in. And part of sparring back and forth with Yoni led me to the place we're in. And so it was a pivotal moment.
That's great. Who else should I have a conversation with here, going direct?
That'd be a really good one. I could probably give you some good names if I put some thought into that, because I've backed a lot of businesses where I think there's a theme here around
Okay.
unearthing the middleman. And let me give you a couple names,
All
but
right,
I
great.
think that's a great question. Yeah.
And how can people reach you?
Emails. I think my email's on my LinkedIn. Love connecting on LinkedIn or chatting. I'm not super active on other socials, but yeah, alex@meroka.com, website, email.
Great. Cool. Well, Alex, thank you, my man. It was a pleasure. It was great to learn a lot more about what you guys are doing, and it's cool because you're just getting started. So we'll keep in touch and see how it progresses.
Yeah, this is super fun. Thank
Thanks,
you.
man.